Hi, my name is Dr. Gary Lemack. I'm a professor of urology and neurology at University of Texas Southwestern Medical Center in Dallas, where I've been for the last 25 years or so. And my practice focuses on patients with voiding dysfunction, incontinence, and in particular, neurogenic bladder conditions. So patients who have bladder problems in the setting of various types of neurological disturbances, whether it's multiple sclerosis, spinal cord injury, Parkinson's disease, multiple systems atrophy, and others. And that's where I spend most of my clinical time is taking care of patients who have medical and surgical problems related to their bladders. And also kind of my research background is focused in these types of areas with bladder disorders, particularly focusing on neurological conditions because bladder problems are very common in patients who have neurologic conditions, and it's one of the more bothersome things that patients report who have neurologic conditions that have bladder problems at the same time, and can really be affecting quality of life significantly, both of the patient and often of the partner or spouse. Um, the first thing to say about this is it's often been said in the urology worlds that the bladder is an unreliable witness. And what do we mean by that? What we mean by that is that a lot of patients have kind of very similar bladder problems, um, but the problem underneath it, underlying it, or the disorder is very, very different. So, for example, many patients with multiple systems atrophy will have problems with urinary urgency or frequency, or can't make it to the bathroom in time. And many of the times that's due to something called bladder overactivity or detrusor overactivity, or the bladder having contractions at the wrong time. And for that, there's a certain set of solutions or treatments that we can talk about, and I'll go into in just a little bit. But we're often fooled, and it's not always that the bladder is having overactive contractions and it's not listening to your brain and just doing its own thing. But sometimes it's because the bladder is just not draining in it very well. And the manifestation of that is you just have to go frequently because you're never emptying your bladder all the way. And sometimes it's obvious that you're not emptying your bladder all the way, but a lot of times it's not obvious. And so the one thing I would say, and maybe the biggest take home of all of this, is if you're having these symptoms, it's okay to see certainly your primary care general physician and get some advice and start out that way. But often it's more complex, and you probably should be seen by a specialist to do some evaluations because we can do things that kind of look into it a little bit more and give you more insight into what's actually causing the problem. So, as I was getting to, bladder symptoms are very, very, very common in patients with multiple systems atrophy, and part of the problem is that patients who have these types of movement disorders typically are older, typically may have other symptoms and other bladder or prostate problems that you normally would have even if you didn't have the neurologic condition. So sorting out what is coming from something that may be completely unrelated to the neurologic condition, and for that reason may have more easy fixes or treatments versus what may be actually coming from the neurologic condition is really important and sometimes hard to do, even in a specialist's hands. But sorting those things out can be very, very helpful in terms of trying to, get to the root of the problem and see where the actual problem lies. So sorting out exactly kind of what the problem is and just trying to distinguish those types of problems that may be common in patients who have, voiding disorders related to aging, for example, is really critical, comparing that to what actually may be due to neurological problems. So again, the most common symptom is urgency and frequency and can't make it to the bathroom in time. And even that's difficult because part of that problem certainly may be bladder related, but a lot of it has to do with functional changes that folks go through when they have multiple systems atrophy, of course, and mobility challenges and so forth. And so it's also really important to kind of distinguish: is this a bladder problem? Is this a mobility problem? Because obviously those would be handled very differently. If mobility is still is intact and people can get and functionally get to the bathroom themselves, and it's a problem with urinary urgency and frequency and bladder spasms, which we see often, then typically we start with dietary changes, watching what you eat and drink, and spicy food and citrusy fruits and caffeine and alcohol and tobacco and carbonated beverages. Those can all aggravate your bladder. So we'll talk about a bit about those kind of things and make some adjustments and try to go on a very important time voiding schedule. And sometimes those things can really be quite helpful. Getting up at night to urinate is a very common thing in this patient population as well, or even leaking in bed at night. And limiting your fluids a couple hours before bedtime is really, really important, because what we've learned over the years is as people get into their 70s and 80s, they actually double how much urine they make overnight compared to your 20s or 30s. And so there's not a whole lot you can do about that except to really stop your fluids a few hours before bedtime and maybe elevate your legs a couple hours before bedtime to get that urine sort of production earlier rather than after you're sleeping, which we all face. Medications can be helpful and certainly have a role, certainly in patients who have overactive bladder symptoms. Lots of medications that we can use and are somewhat helpful. We do need to be cautious with some of those medications because they have side effects, many of them. So dry mouth, dry eyes, constipation are common. There is some data that some of the more common medications that we use and a lot of other specialties use that include what we call anticholinergics can have effects on cognition. And so obviously something we're really cautious about and really want to watch closely, but it is the number one thing that is typically used for these types of symptoms. The good news is there's a new drug class that has been available for these type of bladder problems that is also available and then be helpful for urgency and frequency. So some options there. When medications fail in this group, and it's really primarily a problem of overactive bladder, urgency and frequency, the good news is we do have some other options up our sleeve. With those other options, they're beyond just medication, so we need to be cautious with them. Any intervention can have side effects, but things like bladder Botox or forms of electrical stimulation can be very helpful in patients with urgency and frequency when the medications don't work. But it's really about getting in and getting to see your specialist and making sure you're a good candidate for that, because it's anything other than just a medication. Good to talk to your physician and see a urologist or specialist and have some testing. That may involve, seeing if your bladder's empty when you're urinating. It may involve a special test called a urodynamic test, where we see what the bladder problem is. Is it a problem of the bladder squeezing at the wrong times? Is it a problem of obstruction, benign prostatic growth? Are you at risk for other things, prostate cancer and so forth, that we need to keep an eye on? So often important to go in, as I mentioned, to get checked. The other thing that we often see in patients who have multiple systems atrophy and neurologic disorders is voiding dysfunction, is an inability to empty the bladder. And at a very basic level, it really comes down to two things. It's either there's some sort of blockage, and that blockage can be a number of different things. It could just be an enlarged prostate. It could be a stricture in a woman. It could be a large bladder drop that's creating a kinking effect. In which case there would be a certain set of solutions. But other times it's just that the bladder is just not contracting adequately. And that can happen in patients with multiple systems atrophy or patients who have prolonged outlet obstruction that eventually their detrusor muscle, their bladder muscle, doesn't work very well. And that's one of the things that a urodynamic test or a bladder function test can be very helpful at sorting out. In the event that there is a true obstruction there that can be treated appropriately and adequately, surgery may be an option for certain patients. In general, we're very cautious with multiple systems atrophy patients in intervening surgically, because one thing we have learned over the years is that the typical things that will help men with benign prostatic enlargement, for example, when they're having difficulty emptying, may not help the patient with multiple systems atrophy, particularly if it's particularly progressed. So we're very careful about that. It's not to say we don't rule out any surgical intervention that might be helpful, but we're very selective in that regard, because we certainly only want to apply this to people if we think it could help them and not cause any other problems. And so we're really cautious in general in that. Having said that, again, looking into it and seeing what the cause is often quite important to kind of offering some solutions up, because there can be some solutions. In certain cases, in very advanced disease, when voiding dysfunction becomes even more paramount and more difficult, and people are essentially in retention, not emptying their bladder very well, then you hear about catheterization. And in general, we try to stay away from catheterization, as long as we can. Having a catheter in your bladder can lead to infections and other problems. It can damage the penis or damage the urethra in women. And so prolonged catheterization, while sometimes necessary, is certainly something we don't do just without some great thought and talking to the family and the patient as well. In the event that somebody really could be helped by a catheter, they're in retention, Obviously, first we try what we call intermittent catheterization, which is where in and out catheterization, where you don't leave it in, and hopefully either the patient can do it or a caregiver can do it. That actually has a lower risk of urinary tract infections if it can be done that way. Um, it can't always be done that way for logistical reasons and other reasons. And if that's the case, then we do go with indwelling catheters when people can't urinate enough on their own. If that's the case, in general, we prefer what's called a suprapubic catheter. A suprapubic catheter is still a catheter that sits in your bladder, still at risk for infections and other things, and does need to be changed periodically. But that's one that goes through your very lower abdomen straight into your bladder rather than through the penis in men or through the urethra in women. And the reason that's better in general, it's more comfortable for people. It's easier to change. It doesn't cause damage to the penis or to the women. Allows for intercourse for people who are sexually active. So there's a number of different, it does open up other options, even allows people to kind of cap it and uncap it periodically so they don't have to wear a bag all the time. So certainly not a be all and end all, but for patients who are in the position where an indwelling catheter can really help them and make their life better and make the life better for their significant others or family members or caregivers, it's not unreasonable to consider that, and a suprapubic catheter can often be very helpful. There are other types of incontinence too that we see in patients, what we call stress incontinence. That's not as common in patients with multiple system atrophy. That's the kind of leakage people have when they cough or strain their sneeze or push or that type of thing. So we do see that occasionally in multiple systems atrophy patient. That has a different set of solutions altogether, typically surgical solutions, but much less common in the multiple systems atrophy group, who typically have problems either voiding dysfunction, difficulty with bladder emptying, or overactive bladder symptoms. So what I think I'd really like to leave you with is there are a number of different types of symptoms that people can have, whether it's incontinence, going to the bathroom frequently, getting up at night to urinate, difficulty with bladder emptying, urination kind of, and it's really hard to say that one size fits all for the treatments. So particularly when it becomes more problematic, you start having infections, or you're having to wear too many pads, or these types of things are really impacting your quality of life. It very well may be due to the multiple systems atrophy, and there may be some interventions that truly can improve the quality of life for patients and for their caregivers and family members. So getting that checked out, being evaluated appropriately, checking out the bladder function, checking out the sphincteric function can really help us arrive at some treatment algorithms that would be very helpful for patients and their families. Thank you very much.